Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Dan Salmon, a Johns Hopkins vaccine expert, about how some governments in Europe suspended AstraZeneca's COVID-19 vaccine last week when a tiny fraction of people reported dangerous blood clots after receiving it. They discuss how exactly scientists determine whether there's an actual link between the two or whether the cases just happened. They also discuss how experts make decisions around safety with vaccines. Just a note that this conversation was recorded on March 17th, and that since then, the European Medicines Agency has concluded that the vaccine's benefits outweigh the risks. Let's listen. Dan Salmon, thanks so much for joining me.
Thanks for having me.
So today I'd like to talk about what's in the news, which is the AstraZeneca COVID-19 vaccine. Several European countries have suspended its use because there have been some links, they think, to blood clots in people who've had the vaccine. My understanding is that of 17 million people in the EU and the UK who received the vaccine, 37 had blood clots in the brain. So talk to me about what that means to you as someone who studies vaccine safety.
Yeah, so I would address this a couple ways. And let me just say, I've only seen the real data out of Germany, so I can speak specifically about this situation in Germany. But let me start by talking about this broadly. Bad things happen to people every day from a health perspective. People have heart attacks, people have strokes, people get infectious diseases and chronic diseases and cancer. People get hit by cars and shot by guns. And if you vaccinate people, these things will happen after people got the vaccine by chance alone. And how frequently these things happen, it depends on the population, right? Some cancer, cardiovascular disease, or you name it, is more common in some populations than others by different parts of the world, by people's race and ethnicity, by their behavioral choices, by where they live. Age is often a big factor when it comes to disease. And how you measure it has a lot to do with how frequently you find it, right? The more you look for something, the more you find. And the closer your case definition, the smaller the case definition, the less cases you find. Some things have very clear case definitions, and sometimes they're really quite complicated in medicine. So if we vaccinate a lot of people in a short amount of time, we have to anticipate that bad things will happen to them, hopefully at the same rate that would have happened anyway, except for the disease you're vaccinating against, in this case, COVID. Hopefully that happens less, right? But you can anticipate these bad things will happen. And the question is it because of the vaccine, and specifically more frequently after getting the vaccine? So, to see blood clots following a vaccine that is first being given to elderly people and people with pre-existing medical conditions. So that first in and of itself isn't terribly surprising. The question is it happening more commonly after getting the vaccine? What I've seen from the German data, of these 7 cases, 6 were women age 20 to 50, I think, 25 to 50, and they would have anticipated 1 case in that time period. So 6 seems more than 1, which would be suggestive that there might be a problem. But I would give you a bunch of caveats to that. When you look at this type of study of the safety of a vaccine once it's used and you're comparing expected to number of cases, the way that those methods are developed is to be very sensitive. You don't want to miss something. You don't want to look at how many cases compared to what you expected and interpret it that it's not a problem when in fact it is. So it's very sensitive. And as a consequence, there's a lot of false positives. Looking at these type of analyses in vaccine safety in the US, 9 out of 10 times when something looks weird at first and you look at it more carefully, it's not. Maybe there's a lag in data. Maybe it's how you capture the cases. Maybe it's the comparison group or comparison time window. If after you look at the data, you find that it still persists, usually you want to do chart review and look for standardized case definitions and really do a more formal study. So, that's kind of where we're at with this. A lot of data is not publicly available. The report I saw, which is publicly available from Germany, suggests 6 cases when you see 1. So they're probably looking at them a lot closer. And they're looking at their methods of ascertaining cases between what was expected and what was observed, looking for patterns like the days after vaccination. Do they cluster together temporally? And if in fact it seems to be an issue, well, they may revisit the risk-benefit analysis. They may change the recommendation for use, which now they've suspended it, so they're giving themselves some time to look. And I think, I've seen in American media where people have been critical of this, as well as in Europe. And to me, this says the system's working. They're looking, they're keeping a close eye on things. If something looks weird, they're being careful. You have to recognize that stopping the vaccine comes at a risk as well, because those are people that aren't getting vaccinated in the midst of a pandemic. But with that said, they want to be careful with safety, and that's a good thing. I think we need to see what things look like across Europe and other places that have used this vaccine. If this is, in fact, a pattern that's seen elsewhere, you need to look at the risk of these blood clots among women in this age group and how much risk is it, and then compare it to the benefit of the vaccine. Because at the end of the day, it's all about risk versus benefits. So, for example, flu vaccine causes Guillain-Barré syndrome in 1 to 3 per million people vaccinated. So Guillain-Barré is a pretty serious neurological condition. However, it's a 1 to 3 per million chance. And the benefits of flu vaccine are far, far greater than that.
So you say the system is working because we have suspended these vaccines in light of this data. Others, as you say, are arguing that this is, why are you doing this right now? This is hurting the vaccination campaign when we're trying to eradicate COVID. So talk to me about how to best weigh these risks and benefits.
Yeah, I wouldn't say that the system is working because they suspended use temporarily. I would say the system is working because they identified something that looked unusual and they're assessing it rapidly and making decisions from there. The decision to suspend it is a difficult judgment call, and you don't want to suspend something absent reason because it just confuses people. And potentially you're not vaccinating people when you could. But when I look at the German report and the way this is being handled, it tells me they're doing the right type of science. They're doing it rapidly. They have access to the right data. And that tells me that it's working.
So I know something you've studied is vaccine hesitancy. And my question to you is, does this hurt the cause? There's a lot of people out there who are reluctant to be vaccinated. And here you're telling them, well, this one has these risks, and while it's very a very small risk and it's very specific, that could really blow up and become a PR problem.
So you have to think about short term versus long term. In the short term, this might cause some issues. It may result in some people not getting vaccinated who would otherwise get vaccinated. But we're not in it for the short term. We're not going to eradicate COVID anytime soon, if ever, which I doubt. And this is not the only vaccine we use, nor will be the only pandemic we encounter. And we're really fortunate to have multiple vaccines that look extremely good so quickly. It's really a tremendous success. This is about long-term trust and confidence in the system. And you can ask yourself, do you want a system that looks really hard for unusual, unexpected things? And when it sees something weird, has really good science and scientists to investigate it to determine whether or not it just appears a little bit weird or if it actually is weird, and if it is a problem, among whom, and how frequently, so that when you and your doctor decide whether or not to get a vaccine, you have the best available information? Or would you rather them just kind of not look and pretend it's not there and tell everybody it's okay and provide reassurance absent science? Because if they did the science and told you about it, you might question it for a moment. I think the answer is clearly that people want the latter. And so this isn't just about, yes, there may be a short-term hit. There may be. And that has to be considered, and words have to be chosen carefully. But we need a robust process. It needs to be objective. It needs to be driven by science, and it needs to be reasonably transparent. So, it doesn't mean that like every conversation should be put on the web, but the public needs to know that there are independent, credible, very competent people looking at issues carefully, and they're taking a cautious approach. I know that's what I want, and I think that's what most people want.
Absolutely. Now, just so people know, AstraZeneca is not currently approved for use in the United States, but is perhaps in the pipeline to be considered. Is that correct?
Yeah, I don't think that they've submitted a request for emergency use authorization. So the process starts with the person requesting permission, which is usually a company, and then the FDA responds to that request. And I don't think they've yet submitted a request for emergency use.
Mm-hmm. I wanted to ask one other question. It's related to this. So a lot more people are being vaccinated now in the United States, which is very exciting. And so we're going to see more of these sort of incidental things that happen to people who happen to get a stroke or happen to have a heart attack, which is most likely not related, but it might happen in the week after that they get a shot. A friend was telling me that a teacher in their school district had a stroke a week after she had her shot. And now that's sort of causing all this buzz in the community about whether the vaccine is safe. How do we reassure people about this whole concept that things happen?
Yeah, it's a huge challenge. I ran the safety monitoring program for 2009 H1N1 vaccines for the government. And we did two things. We published a paper in The Lancet, which is a very well-known international journal. And we measured the background rates of lots of different things, from heart attacks to miscarriages in different countries using different methods. And we said, this is the sort of thing you can expect. And in fact, you should expect. And then we held tabletop exercises with the heads of major media, all the outlets. And we had, the Assistant Secretary for Health and the Assistant Secretary for Preparedness and Response and the CDC Director. And we walked through different scenarios. And exactly as you've described. And we said, well, what kind of questions would you ask us? And then they would ask us and we would answer. And then we showed them that paper. And we said, hey, we haven't even started vaccinating people yet, but we've already published this paper to describe this phenomenon, because this will happen. So when you hear about this teacher that had a stroke, and then 50 more people find each other on the internet that all had a stroke within a week of getting the vaccine, don't presume from temporality that one thing happened after the other, causality, which is that one thing causes the other. And that's a very common heuristic. And it's natural and understandable that people assume causality from temporality. But that's what we have science for, is to figure out whether something was by chance or not.
So in the end, science will have to tell us whether those who got blood clots got them because they got the AstraZeneca shots, or they just happened to get them.
That's exactly right. And it's science that needs to drive this. It's science that led to the development and testing and evaluation of the vaccines. And this is a question that can and should be answered, and it will be answered by science.
Dan Sahlman, thank you so much for walking us through this.
Have a good day. Thank you.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.